two quick comments. One, some of you were astute enough to ask about your cell phone. Now they have a control over how much blue component of light, because at nighttime, when most of us try to go to sleep, one of the signals for sleep is melatonin levels secreted by the pineal go up. And normally melatonin levels is inhibited by melanopsin input. And so if you're watching a lot of things on your iPad in bed, and there's a lot of blue light component in the monitor, you're kind of preventing yourself from going to sleep. So that's why some of these devices now have a control to reduce the amount of blue light in your smartphone. So it's getting really smart, the smartphone. And Dr. Hummer reminded me, I didn't mention that some patients can have a lesion in the midbrain in the pretectal area. Remember I said that's where the first synapse of the melanopsin ganglion cells. So you can have think of a tract lesion, but not a tract lesion in the optic tract, a little further distal, where just the pupillary fibers are affected in that brachium of the superior colliculus I showed in the diagram. So the pupil will behave like an optic tract lesion, but there'll be no visual field deficit because it's past the visual pathway. Yeah. Let's see if I have, I have diagrams in the other lecture. I said in some circumstances you can have a lesion in the midbrain, in the pretectal area, that will give an afferent pupillary defect, similar to what you would get with an optic tract lesion. But this is distal to the optic tract and not affecting the visual pathways. So you would get only, they call it midbrain RAPD. So that's the one circumstance where you get an RAPD, no structural loss, and no functional loss either. Usually those patients have some ocular motility problem too because of the location of the lesion.
How can we diagnose it? Diagnose it if we have no structural change?
Because if you have no visual field defect and no structural loss and have an RAPD, then you're expecting something only affecting the pupillary pathway, not even the visual pathway. So not compressive lesions. So those are not very common, but they can happen. But Dr. Hummer wanted a good astute observation to remind people that can happen. Yeah, okay. Let's see, what's our time limit? When do we break?
9:55.
Okay, remind me. This is going to be case driven. I want to show different cases to illustrate different points. First, we'll give some basics, and then we're going to have some cases that you're going to tell me what's wrong. Okay. I want to give this presentation in the context of efferent pupillary defects. If you see a difference in pupil size in anisocoria, when should you worry? What's benign and what could be dangerous? Because you don't want to miss something that's going to potentially, be life-threatening. So it's important to kind of have that idea. So when should you worry? First of all, if you see an anisocoria that's accompanied by other cranial nerve palsies or diplopia, I start to get very worried because that's involving now the third nerve, right? And if you hear a patient say they have the worst headache of my life, I worry immediately because those are usually sudden expansive lesions, like hemorrhages or tumors that are expanding rapidly. If you have a severe headache or facial and ear pain, we're going to show an example. and you have an anisocoria, that means something special. And also children with an acquired Horner syndrome. You look at their baby pictures, they didn't have an anisocoria. Now they have a Horner syndrome and they didn't have any cardiac surgery, no neck surgery. You worry about neuroblastomas. So children, special category of anisocoria, you have to start thinking about these things. And so we kind of touched on what you should worry about when you see the unequal pupils with some of those other findings. So two main areas you're thinking about: the oculomotor nerve, so that would be rapidly expanding masses or aneurysms, or Horner syndrome. So that would be tumors along the sympathetic pathway, carotid dissections, brainstem stroke. So when there's an anisocoria, you have to sort out whether it's on the sphincter side or the dilator side, and then whether these other findings that make you worried to investigate further. I gave Dr. Hummer and Rafi a PDF. You should have it. You're sharing the drive with them, right? With this file. This is focal points that the American Academy of Ophthalmology, that Julie Filardo, she's a former fellow of mine, she's at Portland, Oregon, and I put out, that takes you through what I'm going to give you in this lecture. How do you sort out an anisocoria? What is it, the sphincter or the dilator, or is it benign? So this is kind of a diagram to help you. Remember yesterday in the skills session I said, the first thing you do is shine a bright light in the situation, bright as possible, because you're seeing the patient in room light with an anisocoria, and you add bright light and you want to know, does this difference become more noticeable? If it does, then it's the bigger pupil that's the abnormal one, and this is your differential. Or if it becomes greater in dim light, you start worrying about Horner syndrome. And in bright light, the difference becomes less. Because remember, if the dilator muscle is involved, you add bright light, you're not activating the dilator muscle, only the sphincter muscle. So any dilator weakness is going to be de-emphasized. You won't see much of a difference. But you will see a difference in dimmer light when you are activating the dilator muscle. So think about the conditions of lighting, what it's doing to the parasympathetic versus sympathetic side. So let's go through some causes of anisocoria increasing in bright light. So that was over here. So we're talking about benign causes like a postganglionic 80s pupil, pupil involving third nerve, drugs causing mydriasis, and then cases where there's direct damage to the iris sphincter, not the nerve, but something is damaging the iris sphincter directly. And then we're going to talk about anisocoria that increases in dim light. So that would be sorting out the difference between physiologic anisocoria and Horner's. And we'll talk about what is physiologic anisocoria. Here's a patient that he was about 50 years old, and he remarried. And he was, right before he got remarried, he went to the Mayo Clinic and got a 50,000-mile checkup, make sure he was okay before he went and got married and went on his honeymoon. He was fine. He went to Denmark with his wife from the US, and were on the docks in Rotterdam, and he slipped and fell on the dock. And didn't think anything of it, but then within a day he started getting a lot of tooth pain on the left side. He felt like he had something wrong with his teeth, a lot of pain in here. As a matter of fact, it was so disturbing that they had to stop the honeymoon and go back home. And he went to his dentist, and the dentist promptly took out a few teeth. And he still had the pain. And he was shaving in the mirror and noticed, hey, my one eye looks different than the other. Went to his ophthalmologist, and the ophthalmologist saw this and recognized that, well, the reason the eyes looked different was two reasons, right? First of all, the eyelid fissure was different on this side, and also the pupil was smaller. And so the ophthalmologist was the one that really, saved the day. And this is what they saw on the, we showed this video yesterday. Let's show it one more time. So first he saw more space here because this eyelid was up higher, called upside down ptosis, in addition to this lid being lower. Here's the bright light on, the anisocoria is less. The light goes off. This pupil dilates quite fast. Now the anisocoria is maximal. And if you wait long enough, as we showed yesterday, this pupil keeps dilating slowly, not as much as this one. Because remember we said the antagonist muscle, the sphincter muscle, is inhibited at a central level. So when you turn off the light, you inhibit the antagonist to make the pupil passively dilate, and then you stimulate the agonist, the dilator, to kind of turbocharge the dilation. So he noticed this was a Horner syndrome. And if you have a computer pupillometer and graph here the actual pupil size of the right and left side, you see that in dim light there was about 1 millimeter anisocoria, almost. And as the pupil contracted, that difference is less, right? That's what we showed. Adding bright light, the difference becomes less. We turn out the light, and this pupil dilates quite fast, and this one's much slower. So at 5 seconds after the light goes out, you're in your lane, turn on the light, take it off. 5 seconds, the anisocoria is the greatest. And if you keep waiting, because the parasympathetic is inhibited and the sphincter is inhibited, this smaller pupil does continue to dilate. So the anisocoria at about 15 seconds is less. And that's what people call dilation lag. And the only thing that causes that is a sympathetic deficit. It's very specific. So it's an important sign if you see it. So he had, remember, this toothache and facial pain. So what it causes a Horner syndrome and facial pain. Do you know the cause? Very specific. You need to learn this. A carotid dissection, yes. So whenever you hear about a patient, they're talking about ear pain, facial pain, jaw pain, and the pupil's smaller on that side, you think it's a Horner's. That's a carotid dissection. And remember that in young people, that's the most common cause of stroke. Because you get a dissection, you get a mural thrombus, and then it goes up. And you could get even a central retinal artery occlusion have been reported with that too. So make sure you remember Horner syndrome and facial pain, that's a red flag. And you can see the carotid dissection here. Here's the blood in the wall of the carotid artery on the left, and here's the dissection. Okay, used to be 15 years ago and before, let's say you weren't sure about the dilation lag. There was a little bit of dilation lag, but just not positive whether it's a Horner syndrome. And you want to confirm pharmacologically. And I just want to say one thing about that. Most Horner syndrome is partial. Most causes of Horner's don't completely take out the whole sympathetic nerve. And so a partial Horner's is going to give some signs, but not bowling you over in the lane. And so the amount of fibers that are affected will determine how obvious the signs are, whether it's ptosis or anisocoria or dilation lag. If you're only affecting 25% of the fibers, it may not be all that obvious, like some of the examples I showed that are obvious here. So pharmacologic testing is important. And we all used to use cocaine to do that. Remember what cocaine does. Cocaine, normally, when the sympathetic nerve fires, it releases the norepinephrine packets, right? And normally that's broken down. And it's also taken back up into the nerve terminal to terminate its action. Cocaine blocks the reuptake of norepinephrine back into the nerve terminal, so it accumulates in the synapse. And that gives mydriasis. And that's, people get a high from cocaine because it's like an amphetamine. It's kind of your normal stores of norepinephrine are being released and are accumulating, so you get high. And that's also, if you put it in as a drop form, the normal pupil should dilate after about 50 to 60 minutes. You wait about that long. Now it's important if you do a cocaine test not to let the patient go in the waiting room and take a nap, because you want to have their sympathetic system being activated during the time the cocaine is in there to release norepinephrine so that it accumulates, okay? So patient with a Horner's syndrome, the normal right pupil will, after 60 minutes, will be dilated, and the suspected Horner's side may dilate a little bit because it may have some intact fibers, but not nearly as much as that side. So you produce an anisocoria because of a negative effect of cocaine on the affected eye and a positive effect on the normal eye. So here's a patient. This is kind of what you'd see after the cocaine. The anisocoria in room light increases because the normal pupil gets more dilated and the other pupil doesn't affect that much by cocaine. And what's a positive cocaine test? One of the first studies we did back in the late 1980s is we took normal subjects and gave them cocaine in each eye. And after 60 minutes, this is the amount of anisocoria in the normals. And all the Horner's patients that were diagnosed by other means, this was the distribution of their anisocoria. So right in here is the gray area. So statistically, we found that if you had about a 0.8 millimeter anisocoria or more, you almost certainly have a Horner's. If it's in this area, the test is in the gray area, being positive. And statistically, the cutoff was about there, was a pretty high odds ratio, and the person would have a Horner's. So that's just a guide if you use cocaine. Why cocaine isn't used that much anymore? It's a controlled drug. You have to have it under lock and key. The half-life is only about a month. And most ophthalmologists, they don't want to bother with all that. It's just too much. And so about 10 years ago, a new way of diagnosing Horner's syndrome was recognized using aproclonidine drops. Let me tell you a little story about how that happened. Sandra Fraser Brown was an ophthalmologist in Houston, Texas. And aproclonidine came out before brimonidine. So aproclonidine was developed when patients were getting a YAG laser capsulotomy or an iridotomy to put it in the eye at that time to keep the pressure from going up. And the mechanism of action is that it's an alpha-2 adrenergic agonist. So remember from pharmacology, there's alpha-1 receptors and alpha-2 receptors. Alpha-2 receptors are on the presynaptic terminal. It inhibits the release of norepinephrine. So if you have the alpha-2 agonist, you actually prevent the release of norepinephrine. And the reason it lowers eye pressure is that the ciliary processes that produce aqueous are innervated by the sympathetic nerve. And so for the ciliary process to produce aqueous, you need alpha-1 stimulation. But alpha-2 will inhibit that, and so it lowers the production of intraocular pressure. So Sandra Fraser Brown, she said, that's really the mechanism. And if I take some patients with Horner's syndrome and give them aproclonidine, it shouldn't really lower the pressure in the Horner's eye, right? Because they already have a lesion. It should only lower pressure in the other eye. And she did that. And it worked, but she noticed a surprise. She noticed in the patients she gave the aproclonidine to, had the Horner's, first of all, the normal pupil got smaller because you're inhibiting sympathetic release, right? So you're actually producing a Horner syndrome in the normal pupil. But what was unexpected is that the Horner's pupil got bigger. Why? Because aproclonidine is not a pure alpha-2 agonist. It has a weak alpha-1 properties. And in a normal pupil, the alpha-2 predominates and you get reduced pupil size. But if you have a Horner syndrome and you get supersensitivity or upregulation of the alpha-1 receptors on the dilator muscle, then a weak alpha-1 agonist gives a big effect because you have supersensitivity. And that's what causes the increase in pupil size here. And how long does supersensitivity take to develop? What do you guess? Let's say I did something and caused a carotid dissection today. How long do you think it takes to happen? How long will it be before they get supersensitivity and then a positive aproclonidine test? Do you have any idea? Guess. Huh? 1 week? That's a pretty good guess. So actually it starts at about 48 hours. 72 hours, it's usually definitely there. So it happens pretty fast. So the reason I say that is that if it's an acute Horner's, within 2 days, the aproclonidine test isn't going to be positive. It takes about over 2 days for that to happen. So think about that. Cocaine test would be positive right away because no release of norepinephrine is happening in the Horner's eye, but it's happening in the normal eye. But besides the pupil, you notice what else is happening here.
Why will you take 2 days to make a first time?
Oh no, it happens within 30 minutes after you give the drop. It's just, if you have a Horner's that started today, it'll be at least 2 to 3 days before the supersensitivity occurs. Okay? But what else is happening here besides the pupil? The eyelid. Yeah. Because remember, Mueller's muscle, that's why the lid's down, it's innervated by sympathetics. And what's remarkable is if you put aproclonidine drops in both eyes in a Horner's patient, the pupil takes about 30 minutes to dilate in that side. The lid happens within minutes because the aproclonidine goes right up through the conjunctiva in the Mueller's muscle, where it takes about 30 minutes to penetrate the cornea in enough concentration. So the family is just amazed that you solved their ptosis within minutes by putting this drop in. So you have 2 end organs to monitor for a positive effect, both the eyelid and the pupil. So after you make the diagnosis of Horner's, what's next? Well, you need to know the cause and what's going to happen to the patient. Is it serious or is it something not so serious? And does it require treatment? And so most neuro-ophthalmologists get an MRI at this point to look along the pathway. Now, I don't have enough time, but remember the sympathetic nervous system has it's a 3-neuron chain. The first neuron starts in the hypothalamus, descends the brainstem into the spinal cord, and synapses in the lateral spinal cord. And the second neuron loops around the subclavian artery and then synapses in the neck at the superior cervical ganglia, right at the carotid bifurcation. And then the third neuron travels along the carotid artery back into the orbit. So that's obviously why a dissection along the internal carotid artery is going to cause a Horner syndrome. So just another diagram. Remember that first order neuron starts in the hypothalamus. Synapse is right here in the lateral cord. It's about cervical level C7 to about T1, T2. And then the second neuron synapse is in the neck, and the third neuron goes up the carotid to the eye. I'm not going to talk about the hydroxyamphetamine test because this is a drug that is not widely available anymore, but I just want to tell you just a minute about it so you'll remember that some people still use it. This is a test to try to localize where the lesion is. Is it the first or second order, which is preganglionic, or the third order? So it releases norepinephrine from the nerve terminal. So this is a preganglionic Horner syndrome, and hydroxyamphetamine is releasing any stores of norepinephrine, dilates the pupils if the postganglionic neuron is intact. So if there's a neuron there, it may not be firing because the lesion's before it, but there's still stores of norepinephrine, so both pupils will dilate. If it's a postganglionic neuron, those stores are gone because the last neuron in the chain's been damaged. And so that pupil will not dilate as well. So some people still use this pharmacologic test to help localize, to know where on the MRI scan you should focus your attention. Children, just a couple quick things about Horner syndrome in children. First of all, if you make them cry, often you'll see a blushing or a redness on the normal side, and on the denervated side, they don't have as much. And you can kind of even tell by the distribution of this where the lesion is located. If the Horner syndrome is acquired congenitally or during the first year of life, you'll get a difference in iris color. Because remember, melanocytes in our iris stroma is what gives the iris color, right? And those are neuroectodermal. Those are innervated by sympathetic nerves. And in order for the biochemical machinery to develop, those melanocytes have to be innervated. And they accumulate pigment during the first year of life. So if you don't have sympathetic innervation, either during birth or from a surgery that happened during the first year, the iris on that side will not ever accumulate as much pigment. And so it'll look lighter color. So it kind of dates when in their life they have the Horner syndrome. I'm going to go forward here a little bit. So just things to think about with the Horner syndrome are tumors, artery dissections, and stroke. Those are the dangerous ones. I always ask the patient about history of surgery. Tell them why you're asking the question, because they're thinking about eye surgery, and you're asking them, are they had any surgery in their neck that could damage the sympathetics? Are they had any surgery, open heart surgery that could damage the sympathetics? Lung surgery, neck surgery, thyroid surgery. So ask the patient about previous surgeries to see if that's the cause. And sometimes getting the family photos is nice to document how long they've had it. Obviously, if they've had it a number of years, the more dangerous causes kind of fade down a little bit. In the last 15 minutes, let's try to cover the efferent side on the sphincter muscle, where the antiscoria gets worse in bright light. I'm showing this case, it's an old photo, because I saw this patient as a fellow, and I made a big mistake. So I learned from that mistake. I'm going to hope that you learn from my mistake. The patient didn't look like this a month before. A month before, this patient was referred for a temporal artery biopsy because of a lot of headache, pain on this side. And she had normal motility, normal eyelid, but there was an anisocoria with this pupil being larger on this side compared to this side. Still reacted to light, but with bright light, there was still a 1 millimeter anisocoria. And I was a fellow then, and I blew it off. I thought, wow, there's no motility problem. She's here for a temporal artery biopsy. Don't need to.
Did you make any MR or CT?
No, because I thought it's just an isolated, mild efferent defect. That doesn't have anything to do with temporal arteritis. There's no motility problem. I just thought, don't worry about it. We did the biopsy, it was negative. And then she called me a month later and said, I woke up and my eyelid's down. And I lift the eyelid and the eye's out, and the pupil's even bigger. So at that time, she got an angiogram and had a posterior communicating artery aneurysm. Now, most of the time when you have an aneurysm affecting the third nerve, you'll get pupillary changes and obviously other third nerve changes, but not in every case, and not in this one. What was unusual is that it really preceded the motility problem by weeks, and luckily nothing bad happened to her, but that was a mistake.
One day headache?
She had a headache. She was referred for temporal artery biopsy. So remember, this is a diagram. This is the orbits this way. This is the olfactory nerve. This is the posterior communicating artery, and this is the third nerve. The reason I'm showing you this picture is that the posterior communicating artery lies on the medial side of the third nerve. Okay? And the reason that's important, and I'll cover this in the third nerve lecture after lunch, is the pupillary and accommodative fibers lie on the medial side of the third nerve, on the intracranial portion of the third nerve. And that's why things that compress the third nerve from the medial side usually affect the pupil and accommodative fibers early, because they're the first part of the third nerve that's next to the compression. And that's why you normally do see with aneurysms, pupillary involvement. And if they're young enough, then you can measure accommodative paresis as well. Here's another patient that came in, worst headache of their life. And let's look at the video. So the pupil's bigger on that side, no question about it. They can abduct, they can't elevate that eye very well. They can't adduct that eye very well, and they can't really infraduct that eye very well either. So, no question, that's a third nerve palsy, right? And it's pupil involvement. So, what do we do now? What's next? Lumbar puncture. Okay. How come lumbar puncture? What are you looking for? Meningitis. Okay. So, that would be 10th down on my list.
Take a good history about patient, other diseases like patient hypertension, diabetes, and other things which can cause medical therapy.
Okay. Do you think if you had a diabetic ischemic third, what's the likelihood the pupil would be involved? High or low? Huh?
It's not that.
Okay, well you said diabetes.
Yeah, no, I was probably concentrating on something else.
Okay, all right. So what are the things you're thinking about? What are you going to do next? Pupil involving third.
Aneurysm.
Okay, aneurysm. What are you going to do? MRA? MRA was negative. What do you, before you start ordering tests, what I want you to do is think about a differential diagnosis. Then think about what test you want to order. Okay? Let's not jump too far ahead. I just primed you by showing you a patient with an aneurysm before. I'm digging a hole for you to fall into. Okay? So what's the differential diagnosis of a pupil involving third nerve palsy with pain, with headache? Well, aneurysm, we said, that's easy. Put that off the list, that's over here, it's top of our list. What else? What other mechanisms? Tumor. What kind of tumor would cause an acute, abrupt third nerve pupil involvement? Do you know? So it has to be something that's suddenly expanding, right? It's not a slow-growing tumor, it wouldn't do that. Lymphoma? So lymphoma could do that, or leukemic infiltration. Probably wouldn't cause pain, because it's infiltrating the nerve. It's not sudden expansion.
leading to the similarity.
Okay, pituitary apoplexy. That's a very good one. That's my second on the list. So a pituitary gland that outgrows its blood supply gets edematous and can have hemorrhage. Can have edema and hemorrhage, or either one, causes sudden expansion. And if it expands laterally, the third nerve runs along the lateral aspect of the pituitary. You can get unilateral or bilateral third nerve. If it expands upwards, you're going to get visual field defect. We've had some patients expands upwards and out, you get visual field and third nerve palsy. It's very localizing. So yes, that's the second on my list. So you got the two biggest ones, aneurysm and pituitary apoplexy. Now the hard ones come. Cavernous sinus thrombosis. Well, you probably see other cranial nerves and other signs besides an isolated pupil involving third.
Dissection?
35, let's say.
So,
Oh, correct. Giant cell arteritis. So that's been reported to cause. So that's a good one to think about, but not in a young person, but definitely on the list. Giant cell. Getting there. Subarachnoid hemorrhage. Well, if you had a subarachnoid hemorrhage that was causing herniation, that person wouldn't be in your clinic, right? But yeah, you'd have to have other big neurologic problems, right? But okay, that's on the list. But think about mechanisms. Compression, I said, aneurysm, tumor. Granulomatosis. Oh, granulomas would be giant cell. Or how about mechanisms? Ischemia, we said unlikely. Very small number of cases can affect the pupil from ischemia, so it's not unheard of, but we don't advertise that because I don't want you to diagnose ischemia as the first cause of a pupil involving third nerve. But so
Compression.
we said compression. Oh, what other mechanism? Well, we said inflammatory. Are there other types of inflammation that cause pain in pupil involving third? Yes, Tolosa-Hunt. So that's another one that would be on the differential.
which one?
Tolosa-Hunt syndrome. It's like a idiopathic inflammation.
Tolosa-Hunt will have proptosis.
Not necessarily proptosis, but it may have other cranial nerves, like fifth nerve,
It
maybe.
cannot be just third nerve function.
It can be. It can be.
I don't know.
Yeah.
Never read in literature Tolosa-Hunt only third nerve function.
Yeah, it can be. But inflammatory, so that's in the area. What else did we not cover?
But why should you have a neck stiffness if it is Tolosa-Hunt syndrome?
Pardon me?
Why should you have neck stiffness if it is Tolosa-Hunt syndrome?
Because it's part of the whole pain syndrome. Okay, we got most of them. Ophthalmoplegic migraine, we're going to cover that after lunch. Dural cavernous fistula. Normally you think about a red eye with a dural cavernous fistula, connection between the artery and the vein. But sometimes these fistulas can drain posteriorly instead of anteriorly. And if you think about the veins that drain blood from the base of the brain, the inferior petrosal venous sinus, that travels right along the 6th and 4th nerve. And so if you have a posterior directed fistula, you can get a third nerve or a 6th nerve palsy without the redness. It's called a white eye shunt. So you're used to a red eye because that's how they present to ophthalmology usually. So a shunt can do that. We see it rarely in the third nerve. Now, one little pearl. Diabetics who come in with a third nerve palsy. And the pupil reacts, but it's still with bright light, not reacting as well. So the question is that pupil defect, was that there before the ischemic third nerve? Because diabetics can get efferent pupils for a number of reasons. First of all, if they've had panretinal photocoagulation. I don't know if you've noticed, but it affects the pupils. Why is that? Because you're barbecuing the retina. And what underlies the choroidal retina? the short ciliary nerves that go to the sphincter muscle. So you heat up the choroid and retina, and you can produce an 80s-like pupil, and it can be segmental too. Also, diabetics can have autonomic neuropathy and affect the pupil. But almost all the cases that I just said, laser-induced or autonomic neuropathy, if you look at the slit lamp carefully at these patients, you'll see sectoral palsy of the sphincter muscle. So some segments will work and others won't. But a preganglionic parasympathetic lesion that's acute, like compression or inflammatory, I've never seen a segmental palsy. They're almost always post-ganglionic. So a pearl is that if you're seeing a diabetic patient and the pupil's a little bit bigger in bright light, and the question is, are you going to push the panic button, today and get imaging? Is it emergency? If you see segmental palsy with the slit lamp, good chance it was probably there before the ischemic third nerve palsy. I'm not saying you shouldn't work it out, but my worry level goes down a little bit. Yes?
How about infections?
Infection, okay. So what type of infection are you speaking?
Well, I've seen this in patients with herpes
Fungus?
zoster, viral. Herpes zoster.
Zoster.
Yeah.
Yes, good one. So that would be under the infectious inflammatory. So zoster infecting the third nerve, that usually happens a couple weeks after the skin breakout, but you're absolutely right. You can get a zoster vasculitis. Usually those don't involve the pupil unless the zoster involved the pupil from the anterior segment ischemia before that. But so that's right to think about zoster, yes. The other one to think about is diabetics who have fungus infection, and you can start picking off cranial nerves, but usually that's not as painful. Okay, good. So this patient had this pituitary apoplexy that you're seeing here, both edema and blood. And I think we're out of time, aren't we?
Finish off.
Okay, last thing is 80s pupil. 80s pupil is common and it's benign. It's an acute denervation of the post-ganglionic parasympathetic fibers. It's almost always segmental. There's cholinergic supersensitivity within days, just like on the sympathetic side. It only takes a couple days. And after about 8 weeks, there's regrowth of accommodative fibers into the sphincter to give the light-near dissociation. We talked about that yesterday. And when there's a lot of aberrant reinnervation, it keeps the pupil small all the time because the accommodative fibers are innervating the pupil. It doesn't care what the lighting condition is. People call that a little old 80s pupil. So the lesion is here, post-ganglionic. Here's an acute, but it looks like acutely. So darkness, not much difference. Light, there's hardly no reaction here. Bright light's even greater anisophoria. And near, there's not a good reaction either. And if you give dilute pilocarpine to both eyes in darkness, sometimes a normal eye will react to dilute pilocarpine, but it's the difference between the two. So this one got smaller, so there was some supersensitivity. Here's the same patient 6 months later. Look at this pupil in darkness is a little bit smaller than this one now. See, before it wasn't. And it still doesn't react to light. But now with a near response, we're getting some contraction. Remember I showed the video, how you do it with your auditory, and it takes about 10 or 15 seconds to develop. And if you look at the slit lamp carefully, it's not looping. Sorry, let me show this, it's important. Come on. Okay. See, there's this one segment here that's reacting. You wouldn't see that unless you looked at the slit lamp. That's the segment that wasn't affected. All the rest was. And when you have this chronic reinnervation, this tonic pupil, the pupil's not doing anything in different lighting conditions, dark or light, but it does react more to near. So these accommodative fibers are firing all the time. You can activate them more up close, but they don't care what the lighting condition is. And if, I'm going to skip this. This is if you transilluminate, you can see where the sphincter is contracting and where it's not. We did a paper on that. And this is the video I showed yesterday. We'll end here. Remember, this is a bilateral 80, no reaction to light at all. And then look at the near response. You're really having them look at near. It's taking 10 or 15 seconds. Finally, they're starting to come down. And when you have them look off in the distance, they stay contracted for quite a long time. We've got it constricted now, looking off in the distance, because once you get the pupil constricted with a near response, it takes a long time to release. And that's why people call it a tonic 80s pupil. We talked about that yesterday. So, maybe later on, if there's time, I'll give you some mystery cases you can try to work through it. Yeah?
How much time does it need for antipupil to turn from chronic dilated to the chronic tonic?
So the aberrant reinnervation starts at about 8 weeks, and it may take a couple months to fully develop. So if you see a patient that comes to you because of photophobia or asymmetric accommodation, and you see a light near dissociation, you know that it wasn't acute. It's had to have been there for a couple months already, because the aberrant reinnervation takes a few months to happen. And acutely, you won't see any reaction to near more than the light reaction. And you should also measure some accommodative amplitude is decreased on that side if they're young enough.
So it's some months.
Yes, at least 2 months.
Okay.
Okay,
Thank you.
time for the bell.
That was gonna be, yeah.
Thank you.
Gonna be a coffee break for half an hour until 10:30.